Welcome everyone to today's webinar, The Quality Journey of Resuscitation and Its Business Implications. I'm Erica Carbajal, writer and reporter with Becker's Hospital Review, and I will be your moderator. On behalf of Becker's Healthcare, thank you so much for joining us today. CPR is scientifically proven to save lives. When a person in cardiac arrest receives timely, effective CPR, it can double or triple their chance of survival. As healthcare professionals, many of us acknowledge that poor quality CPR is a preventable harm. But we also acknowledge that high quality CPR doesn't just happen, and that CPR training and certification can be expensive and time consuming. And here we are this week, which also happens to be CPR Awareness Week, to speak with some of the leaders from the American Heart Association. The volunteers of the American Heart Association wrote the book on CPR, and we have one of those volunteers with us today, as well as the CEO of the American Heart Association and a clinical educator who understands how the science and data work together and truly impact the patient's outcome. With that, I'm pleased to introduce today's speakers. First, we have Nancy Brown, the Chief Executive Officer of the American Heart Association, and Dr. Ash Panchal from the Ohio State University Wexner Medical Center, and Stephanie Proffitt, Clinical Education Manager of Resuscitation at Intermountain Healthcare. So with that, we'll go ahead and dive into the discussion here. So first, we'll start off with a timely question. How did COVID impact CPR delivery in hospitals?
You know, Erica, I wonder if I could just jump in, first of all, and say thank you to everyone for dialing in today. We're really proud to have Ash and Stephanie here to help talk about the power of CPR and new models for bringing science to market. I also just wanted to acknowledge that this is CPR Week, and so thank you for helping us call attention during CPR Week. And one thing I might just mention by way of background is that the American Heart Association not only writes the guidelines now, but really wrote the book on CPR starting all the way back in 1966. And since that time, we've consistently reviewed and updated these guidelines and the science to make sure that the highest quality care is given to people in hospitals, which is really important since there are nearly 300,000 in-hospital cardiac arrests and more than 15,000 pediatric in-hospital events in the United States every year. I know that Ash will now jump in and talk a little bit about the impact during COVID, but I wanted to say thank you for having us today, Erica, and to thank all of our participants for being part of this program.
Thanks, Nancy.
Thanks for being here.
Yeah, no, I'm definitely excited to jump right in. I mean, I think this discussion is really pertinent and really timely, especially when we think about the impact COVID has on what we were doing. Now, I think the numbers that Nancy just gave you, about 300,000 adults with cardiac arrest and 15,000 pediatrics, really is telling when we put that in the framework of the vast pandemic event that we had. It was evolving, it was expanding, and we know that the severe acute respiratory distress type syndrome that all these patients faced really made it very difficult for us to provide care. And there were challenges in a number of areas, both in resuscitation efforts and even having to require modifications in our established processes and our practices. Now, I think all of us have the feeling about survival from cardiac arrest relies on proven resuscitation and interventions, such as high quality CPR and defibrillation, and all of these done together in seconds and in minutes can really change outcome for patients. Now, this challenge during the pandemic and even now is expanding because we still need to ensure that the patients, with or without COVID-19, are experiencing the best and the highest level of care. Now, outside the hospital, where I spend a lot of my time, I'm a pre-hospital medical director as well as an emergency physician in the in-hospital space, and we saw delays in seeking emergency care stemming from patient fear and reluctance. And these victims of cardiac arrest, heart attack and stroke, were just not getting to the hospital. And so we saw a rise in cases of out-of-hospital cardiac arrest. And a lot of this could be kind of tied to that. And this is associated with worse and poorer outcomes throughout the whole pandemic. And these are the real struggles that we were facing throughout the whole time period.
Absolutely. And I think what you both just shared just underscores the importance of the entire conversation of how critical effective CPR is. And so next year, my next question is as we emerge from the pandemic, we're over a year out, what do you feel will be the lasting impact of these implications or of these interventions?
One thing I might jump in and talk about, just to build on something Ash said, had to do with the number of people delaying seeking care during the pandemic. There was that time period where people were uncertain about hitting 911 if they felt they were having the warning signs of a heart attack or a stroke. And, this is why the American Heart Association launched a nationwide campaign called Don't Die of Doubt, that informed the public that hospitals are the safest place to be in a medical emergency and to call 911 at the first sign of a heart attack or a stroke. And that message, as we sit here today, a year and a half later, is still really important, because even pre-pandemic, there are people who, don't contact their emergency response system if they're having warning signs. That's one really important thing, as well as individuals who may have delayed getting routine medical care in hospitals and through physicians. This is a very important focus point, and I think all of us want to be sure that people are not only getting their COVID vaccine, which is so important, and their flu vaccine, but also making sure that routine medical care continues for people today.
And add to that, I think one of the bigger challenges that with the whole pandemic was how it affects the hospitals, right? So at the same token, you want them to get to the hospital, but the hospitals themselves are having challenges themselves, right? So we're looking at and as a hospital system, at least for my space, what we've started looking at is we wanted to improve efficiencies so that we can make sure that we still have that high level of quality care. And many hospitals were transitioning in a bunch of different ways, right? So we were transitioning from face-to-face time, face-to-face clinical education, to virtual platforms or platforms where we weren't able to engage in such a clear and direct way. And so there are gaps there that we need to address. And these gaps, you can imagine, are even more challenging in more rural or areas where access to care may not be the same, and they may be under-resourced. So things that we really needed to think about through the whole pandemic.
Absolutely. And you raise a great point as well, that it wasn't just routine care that people were preventing or afraid to visit for. It was even more of these serious things of emergency cardiac care that people were also avoiding those hospitals. And Stephanie, how have you seen this play out at Intermountain?
During the pandemic at Intermountain, we had daily communications that was going out to everybody. And the nurses were encouraged. The first thing they started their shift with was to go in and check and see what the daily COVID communication came across as. And it was for physicians and all the leaders around the system, because what was the morning practice may not be that night shift practice, because things were changing so quickly. The neat thing about having the RQI program in place was that we were able to keep all of our caregivers' skills sharp and well practiced with, because we kept RQI going even during the pandemic. We just adjusted a few how to clean the mannequin things, and that was it. You felt like you were doing the right thing the whole time.
Yeah, we saw the same thing at our shop. I thought the most amazing thing that you just brought up there, Stephanie, is how to train people when you don't have the ability to engage them directly. Because when we think about the medical field, so much of this time is this mentored training model where we are there, we are in front of you, we are educating you by a didactic method and saying, hey, let's teach you this. And it became so hard to really train individuals. And in the ICU, we had time together, but in our non-ICU settings, and being on the front lines, like myself as emergency physician and my EMS professionals, it became a real challenge to have a real educational platform. And so having the RQI or something like that, a psychomotor type of station where people could come to, and I don't have to be there in front of them exchanging, vapors, that allows us to actually have people learn the skills and not only that, learn it in a competent manner, which made it a big difference.
We also, thinking back to the beginning of the pandemic at the American Heart Association, we worked hard to think through how could we bring our science to the marketplace? How could we bring new tools and solutions that were science-based to our healthcare providers, to the public? And, very quickly, we all remember back to the days when all of the ventilators were, in such drastic use across the country and especially in certain pockets. And so our volunteers and staff of our emergency cardiovascular care business thought, what are the tools that we can provide that could be digital in nature, that could really matter at this moment? And so we created, just to your point, Ash, on new ways of learning, a digital toolkit for oxygenation and ventilation. Many non-ICU, non-emergency physicians were on the front line needing to know how to provide oxygenation and ventilation to patients, but maybe they hadn't had to do that before. So that was digital learning. We updated very quickly our ACLS training course to include oxygenation and ventilation training in context of COVID-19. And we also built that into the other guidelines and apps that we have available for people. And I think those really mattered. The other thing that we did very quickly to help hospitals and to help us, better understand how the pandemic was proceeding is we created a registry called the COVID-19 Registry, powered by our longstanding Get With the Guidelines Quality Improvement Program platform. And for those hospitals that selected to participate in the COVID-19 registry powered by Get With the Guidelines, we were able to track information on consecutive patients from the moment they hit the ER, through the duration of their care and hopeful, not always, discharge from the hospital. What medications were they on when they came in? What treatment did they receive while they were in? What happened to them during their course of stay? And, tools like this that we, again, had in place since April of 2020 really allow science to progress, because we were able to understand issues around obesity and the different racial and ethnic differences of the outcomes of COVID patients. So I think, Ash, I just wanted to build on your point that new ways to think about products to the people who need them really happened at the beginning of the pandemic. And I'm very proud of the American Heart Association that we were there at the beginning, thinking about how to transition our products to be as relevant as possible to healthcare providers.
And the exciting thing was that early engagement allowed us to do a couple of big things, right? It allowed us not only to be on the front lines of gaining this information, but also translating into guidelines. I was very fortunate to be one of the guideline writers for the interim guidance for COVID-19 and how we would do resuscitation. And it was an amazing amount of individuals from both Get With the Guidelines and AHA volunteers who got together and really talked about this. And serially, we talked about this. We're still talking about this. And being able to be on that front line as a scientist and as a volunteer for myself was thrilling, because it was a real acknowledgement of the hazard that our public was facing and how we can get into that space and intervene in a positive manner. And it was a great collaborative time, even with everything else going around us.
Yeah, Dr. Ash, can you speak a bit more to how this happens in practice in terms of those up-to-date clinical guidelines in practice? Can you guide us through that?
Yeah, sure. I think one of the things that is so hard for us as professionals, and just pulling myself away from the volunteer segment for a second, is that a lot of times science comes out, and there's a lot of science which comes out, and without having some sort of body to translate some of the material coming out, you get inundated with so much data. And so the great thing about resuscitation and the engagement of the AHA specifically, and keep in mind, the AHA engages in a number of different areas: stroke, heart disease, hypertension, and I'm a resuscitationist, so that's my area. And so I can use that as an example right now, and that with the resuscitation guidelines, as we started talking about how we translate that to practice, that became a really big pivotal point. And one of the big steps that AHA has really made when it comes specifically to the concept of resuscitation is really choosing a new standard. And the standard is verified competency with a new clear standard of care. Now let me point that out again, a verified competency with a clear standard of care, because that is something different than what we see in a lot of places. And it takes a lot of ownership to make that step. So I'm just going to share a little slide here, because one of the research areas that I worked on was specifically looking at the concept of verified competency. So when we think about our cardiac arrest patients, CPR is their last chance of survival, right? So when we think about this, if they don't get compressions, oxygen flow to the brain stops, oxygen flow to the heart stops, drugs that you may provide go nowhere, and we know we're in a situation where this could have a very disastrous end. And in truth, we are depending on individuals to provide high quality CPR. So if it was my mom or your mom or anyone's, we want that resuscitation to be the best possible it could be. And so we demand that people have great different things, compression fractions, the rate of how you compress, the depth, the body mechanics. You want to avoid leaning. You want perfect volumes. This is not easy stuff. I mean, the psychomotor behaviors that are demanded from this are phenomenal. And so in truth, how do you actually maintain these skills? And so at Ohio State, we asked a really hard question. The question we fundamentally asked is, how can we maintain these skills and improve patient outcomes? And during COVID, it was even more so for us. We have a group of individuals at our facility. We have 13 to 14,000 people that we certify to perform CPR. That is an amazing number of people. And how do we maintain their competency? And we had a true hard recognition that for a while, we probably couldn't prove that every single person was getting the best CPR until we made a transition. And so the transition we made for our group and everyone at Ohio State was we transitioned to really forcing ourselves to focus on a training platform where we had a couple different pieces. First, we wanted to make sure we did mastery level training with strong deliberate practice. We wanted low dose, high frequency exposures. We wanted the learning to be in the context of the individual themselves. Look, I wanted my nurses to learn on the nursing unit. We wanted feedback and debriefing. We wanted valid assessments. And so to go after this, we actually did a research study to look at this whole question and really chase down what this looks like. And our study objectives were pretty clear cut. The first, we wanted to look at the effectiveness of a low dose, high frequency CPR training platform for the maintenance of CPR skills. So this psychomotor platform, at the time, it was just the new release of RQI. And so this was what our platform was, a psychomotor training station with low dose, high frequency exposures. And we wanted to look at compliance. So for me and our organization, a big piece here was if we have high compliance and we can get training at the location where they are working, we have engagement. We have true engagement that we can keep the care going. And last but not least, we need a real CPR performance data. We really needed to understand if we were really making an impact, or is this just, another training platform which doesn't do anything. And so our methods were, we really looked at three major phases. We looked at the simulation evaluations of the quarterly training that we got from our psychomotor platforms. We looked at compliance numbers. We looked at the clinical skills themselves. Now, this is real patient level data of compression to compression. That's what we looked at. That is what really mattered to us when it came to trying to decide on outcomes. And so with our partners, we had some great things. We found that low-dose, high-frequency, case-based psychomotor training was feasible, and more than that, it enhanced our CPR skills retention. When we looked at the educational outcome for our individuals in our setup, it was amazing to see that from quarter exercise to quarter exercise, they maintained those skills. Now, what do we know about skills retention? In 6 months, they're washed out. 3 to 6 months, people are washing out, and they're not maintaining. We saw this maintenance over time, and that was an exciting piece for us. The second thing was that the training platform had high compliance rates. We were up in the high 90s for compliance, and the reason being is all they had to do was take 10 minutes off from their shift, get covered for 10 minutes, go work with the psychomotor station, and then get back in. They never left the floors. They never left our working space, and it made all the difference in the world. And last but not least, we saw that this training actually led to better patient outcomes. We looked at compression to compression and saw improved compression fractions, which really means that we had much better resuscitations occurring, which is really exciting for me as a clinician. And so when we think about this, and I want to bring this whole system idea, and I'll give Stephanie a chance to chime in here because she's probably experienced this. I just did the research. She's experienced this too, is that when we start from the outside in, we think about the research and the science is being done. And when it comes to guidelines, we develop guidelines not only for resuscitation care, but for resuscitation education. And so much of that resuscitation education guidelines is what we imparted in our psychomotor station. And so this is really guidelines and science coming into real life practice. So thanks for letting me have my momentary diatribe. I appreciate your patience, but this stuff is really exciting, and it really changes the way we look at what we're doing. And with COVID, it changed the game. We didn't have to be there. We didn't have to have in-person classes, and it worked with our 13,000 people in our system. Stephanie, just your thoughts.
Your research is so exciting. And yes, we have seen the same thing here at Intermountain Healthcare. We have found that when we do our simulation practices, that caregivers don't hesitate to jump on the chest and do high quality CPR during the event. And when we're debriefing these events, we ask them, so was that scary for you? We noticed you didn't hesitate. And they said, oh no, I got RQI. I do RQI all the time. It's built my confidence and competence in my CPR skills. In addition to that, I think about the brand new people coming into healthcare, the brand new medical assistants or the phlebotomists or the EKG techs, and they have to have BLS certification, and they get that real-time feedback. They get to learn how to ventilate. They do it correctly in the very beginning of their career. And then I think back to 25 years ago when I learned how to do it, I thought, my technique is so much better now because of RQI. So we see that in simulations. We see it in real-time events within the hospital. And then we take it one step further, and it happens in our communities. We have multiple reports where caregivers come to us and say, because of RQI, I didn't hesitate at the football stadium. I didn't hesitate at Costco. I knew exactly what to do. And one of the girls that came to me said, I'm a pediatric nurse. I don't do adult. I ran a code in Costco on the floor and had AED defibrillated, and the patient survived before the EMS team got there. So yes, those kind of events just get my blood perking and gets me really, really excited. Then to take it one step further, and we enter the data in to get with the guidelines. And then we pull those reports. Those reports go back to all of the facilities. Our big hospitals are really on top of reporting this data out, especially during COVID, because those really, really sick patients got moved to the larger facilities within our organization. And those they wanted the reports. They wanted to be able to be benchmarked, not only with other hospitals. I mean, Intermountain has 24 hospitals now. They wanted to see how they do compared with Intermountain, compared with the state of Utah, and then compared across the nation. And we even had requests for when we to present the same information to our hospital boards. They want to know resuscitation results for all of our organizations. So this is just a super exciting time to be a believer in Get With The Guidelines, RQI, and everything resuscitation related.
Yeah, and Stephanie, I might just say, and to be a believer in quality improvement overall. And, 20 years ago, when the American Heart Association created Get With The Guidelines, we had a vision that if we could help, Ash, to your earlier point, take these guidelines that we write with partners, the ACC-AHA guidelines or the AHA guidelines for CPR in this case, if we could make sure that those became the standard of care more quickly, and that we could help with decision support tools to help busy clinicians and providers at the point of care be able to make important clinical decisions about the care of a patient. And if we could track that information and provide it in a way where we could do the benchmarking within a hospital, among hospitals in the system, and among hospitals more broadly, that we believed that we could improve the quality of care delivered in this country while providing valuable tools to our providers. And that's just what we've demonstrated over the past 20 years. Through the Get With the Guidelines program broadly, we have over 2,500 hospitals and hospital systems that have participated on this quest for better care. And so when we get in the middle of a global pandemic and we need to understand how is our resuscitation working? Get With the Guidelines, RQI, is a powerful combination because that data is right there and helps us understand the quality of care delivered, helps us understand how we're doing compared to others. And, at the end of the day, I think all of us work in healthcare because we care about saving people's lives and helping people have a better chance for a healthier life. And initiatives like Get With the Guidelines, the suite of programs for stroke and coronary disease, heart failure, atrial fibrillation, and of course, resuscitation are such valuable tools for all of us to make sure that the quality of care is high.
It was you just struck me when you said, this was our vision, right? It's amazing to me now when I think about the fact that we've gone all the way from the point of science to verified competency. That's one thing I never would have believed that we could do it, and it's exciting to see that we're living that dream, right? That's actually a dream which has happened, right? Verified competency, where we actually know every 3 months what people are doing. That's an amazing. That's a statement to where we've come through leadership and where we're going to go for the future.
And I think the power of technology meets science, this intersection of science and technology in healthcare is really important. And, I know with all of my heart that our healthcare provider colleagues care most about being as prepared as possible at that point of connection with patients. And so verified competency is the new standard of care. And we're very proud to deliver that through our programs like RQI and others.
Thank you all for your insight there. I know what you all mentioned about retaining skills, that can be sort of concerning. So it's great to hear how those comprehensive training programs, those initiatives have been beneficial. So next here, and we touched on this a little bit, but building a little more, what are the business implication of national benchmarking as opposed to just measuring against the scientific guidelines?
Stephanie, maybe you could jump in on that one.
Yeah. I was going to say, I'll jump in on that one. With experience of reviewing what was going on in my hospital at the time, and I'd look at the quality of CPR and I'd look at the events, but I could never compare to what was going on across any other hospital system within Utah or any other hospital system across the nation. But now I can, and not only can I look at how my hospital is doing, one of the 24 we have, I can look at the bigger ones. We can compare it to each other. We can collaborate to say this practice works really well for us at our facility. Mm-hmm. So the benchmarking is just critical for what we're trying to do in driving change with best practice. It's Mark Harrison, our leader, said, please go. We need to be benchmarked. And so I'm very passionate about doing it. I do it personally for the entire organization. And it's a privilege to be able to do it.
It is exciting because in our system, we have a similar concept where it's the concept of adding and connecting our actual clinical events, may they be poor or good or whatever the case may be, to what we're seeing, analyzing our data, targeting training. So maybe it's an RQI target, right? And really thinking about simulation, or even what's our internal process? Do we have a rapid response team actually close enough to respond, right? So it's really looking at all those pieces that allows us to not only internally benchmark, but then to hold us to a standard. And just like you were saying, Stephanie, that ability for us to look at ourselves in more objective way, because you can look at yourself all day and be like, hey, I'm doing a great job. Look at us, we're great.
Right.
You really don't know. I mean, we don't really know until we really compare.
Right. Absolutely agree.
And I might just say again, these tools for benchmarking, are a really critical part of Get with the Guidelines resuscitation, and they're available, to all hospitals that participate. And the power of objective data, comparing performance, the whole reason we do it at the AHA is to help hospitals and healthcare systems improve their quality of care. So the benchmarking is for you, to make sure that your system is there delivering the best quality of care. And these tools, we hear it in all of the Get with the Guideline programs, whether it's resuscitation or how are we delivering heart failure care? What is our 30-day readmission versus other systems' 30-day readmission? So the tools really make a difference in, making sure the highest quality of care is delivered.
Absolutely. Sounds like, go ahead, Dr. Ash.
Yeah, I just want to add one last thought. And this is just something which has come up over time that I've heard from a number of hospital systems, is one of the things that is really exciting for my system is the public recognition that we do get. Being an organization which is on the front line, and frankly, our research definitely puts us at the front line and the work we're doing, but to be honest, just being involved so that we can report and that we get the recognition that we are at the leading edge of all of this is amazing competitive edge, and really puts us in a different category when it comes to what we're delivering to our patients. And patients know this. Our families know this. People know this as a real thing. So it's something to really keep in mind, especially when we're sitting and making decisions for our long-term success for our hospital systems.
Ash, the recognition really does matter to, not just to the systems, but to the leaders in the system, like both of you, and so many of your colleagues throughout the country who dedicate your lives to making sure that high quality care is delivered at every patient interaction. I always smile because we host recognition receptions when we, hopefully we'll have another face-to-face one soon, for our recognized hospitals in our suite of quality improvement programs Get with the Guidelines. So as an example, at the International Stroke Conference, the world's largest scientific conference on stroke, we recognize the Get with the Guidelines stroke hospitals. And we always smile. You walk in the room and there are just hundreds, and I mean hundreds, 500-600 healthcare providers from hospitals and systems throughout the country who have traveled to this location to receive recognition. And I think it's so important that the benchmarking be used to help improve the quality of care. But to your point, Ash, that we use it as well to recognize good performance of our hospitals and healthcare systems and of our staff who are in the hospitals making this happen. It doesn't just happen. It happens because of really hard work of great people, and recognition helps so much. And it does build the confidence of the public to know that the American Heart Association is recognizing hospitals that deserve recognition because of their delivery of high quality guideline-based care.
Absolutely. It sounds like being able to compare how you're delivering as well as that increased collaboration just serves as a constant motivator. And again, not to ignore, obviously, that the patients do the recognition portion of that, as the patients can see that as well. So next here, I want to talk about these programs that are what you are referring to as the journey to resuscitation quality. Nancy?
Yes. Sorry, I had a little technical glitch. Can you hear me okay?
Yes, I can hear you great.
Yes. Okay, great. I heard a little internet beep. The worst sign when you're on a live broadcast is when something beeps out for just a second. Yeah, so, we do think about this journey to resuscitation quality. And, it's really important to think about the whole package, right? The RQI program that we've talked about, Get with the Guidelines resuscitation, and how those come together to improve the care that's delivered, which is always the first priority. We recognize, though, that there are business implications to performance improvement as well. We can help our healthcare organizations as they're applying benchmarking and effective quality improvement practices. This creates operational efficiency that can reduce risk and can save money for healthcare systems as well. And one thing we do know, and in the spirit of benchmarking and data collection, we do that at the HA as well on our programs and initiatives, is that implementing programs like RQI and the Get With the Guidelines resuscitation actually saves money for healthcare systems. St. Charles last year implemented RQI and saved $1 million during the pandemic and improved patient outcomes. We know that other systems have similar stories to tell. AnMed Health launched the combination of RQI and Get With the Guidelines resuscitation 4 years ago. Its hospital cardiac arrest survival to discharge rate back then was 7%. And by the end of 2019, the rate had climbed to 20%. Prior to RQI, the hospital was spending nearly $200,000 on administrative costs for traditional CPR classes. The first year of program adoption, those costs decreased by more than $100,000. And so we are saving lives, we are improving the quality of care, and we are making sure that the science and evidence-based quality improvement programs position our hospitals to save costs, improve care, improve survival, which ultimately at the end of the day is what all of us want. And the business side of things really matters when you're making decisions about implementing initiatives. Often, I think it feels like, gee, here's another thing I have to do. And so showing the business case for support on saved lives, improved quality, lower costs is important. And with RQI, just think about the days where you're pulling people off the floor and, for 2 days to take traditional ACLS training and backfilling our nurses and our providers. Think of all of the costs that goes into that. And now we've heard Stephanie and Ash talk about the power of the skill-based competence training, and it's a game changer.
Well, and one other thing just to add to that, because it's just so impactful, is the fact that every single time there's an update to a guideline that impacts our level of care, with a flick of a switch, that goes right to your platform. And people learn that knowledge right then and there. When the 2020 guidelines came out, this was the first time that we were able, with a flick of a switch, for all of our platforms to have 2020 guideline-based education. I mean, that was an unbelievable moment for us. And so I think just thinking about this, you're doing all these great things for the hospital-based system, and at the same time staying on the cutting edge. There's not much more you can ask for from that side.
Yeah, exactly.
Absolutely. Can't ignore the business component there. And it's great to hear those real world examples and with AnMed Health. So thank you both for your input there. So when we summarize this beyond the implementation of data or training, what do we really need to understand about the impact to the business of healthcare?
I would just say to the point, that I made a moment ago, I think that from the business of healthcare is changing. It was changing pre-pandemic. It is, I think we've all recognized during the pandemic, the power of more instantaneous information, science-based guideline information, more instantaneous connection between patients and providers that doesn't have to be face-to-face. So the business of healthcare is changing. And our goal at the American Heart Association is to take the guidelines that we write and translate those into tools and resources and care plans and, new ways of training for healthcare providers, as well as for patients. And, the better we all get at that, and the faster the adoption is, the higher quality of care will be delivered. We started this program by talking about people who avoided getting care, emergency care during the pandemic. We also talked about the fact that people avoided their regular interactions with their doctor. I talked about Don't Die of Doubt. We have another campaign we've launched that's called Doctor, It's Been Too Long. wrong. And this is a consumer-facing campaign to get the public back to see their healthcare providers, to get back on their routine preventive care and or medication and treatment regime. No one is going to go back to the way things were before. If I could talk to Ash on a telemedicine thing, if I just need to check in on my blood pressure or my physical activity or whatever my situation might be, I really don't want to slug down to his office and sit in his waiting room anymore. So I think that from a business point of view, it's incumbent on all of us to really embrace these new technology-based solutions, to think about the patient at the center and how we make sure that as we're designing and implementing these new opportunities, that is done in a way that increases patient satisfaction, which matters for the business of healthcare, as well as improves quality and makes sure that the guidelines are implemented at the point of care. And so you can count on the American Heart Association to do our part to make sure that these tools and resources are available and that we're encouraging patients and the public to connect in with their doctors and healthcare systems. It's a really major priority, and I think we see it important. The other thing I feel really compelled to say on the business of healthcare is that we also need to really pay attention, to the disproportionate impact not only of COVID, but of the status of the health of people in this country. And, all of us need to be committed to do everything we can to help people who don't have the same access and high quality care of others, to make sure that we're tooling up our systems and our providers to make that happen. Being very thoughtful about talking with patients about the social determinants of health. Do they have access to healthy food or food at all? Are they living in a safe place? Can they get exercise? What are the barriers to people living a long and healthy life? That is a key determinant of the business of healthcare in the future as well. We must be thinking about healthcare for all people, not just healthcare for people who have, high quality insurance programs.
I love that you said that, because it's reminiscent of everything we do as volunteers and research scientists. We are continuously adapting and being accountable to make more simple and standardized and reduce these variations of care. And we recognize they're there. And we've been talking about a framework today. We're talking about the framework from original research to guidelines to implementation and dissemination, right? And the example we've used today is we're using the recognized example of quality improvement using an AHA platform to really make a decision. And the AHA made the decision when they made the decision to go with life-saving impact with RQI. They gave us a new standard, verified competency. And with that, we've moved forward with trying to improve quality, operational efficiencies, reducing our labor costs, really looking at how we can put this all together. And I think that's the next phase. We have to continue looking at this. And as researchers and as a volunteer myself, one of my big focuses is to continue looking at how we can impart these new standards of care and really change the large dynamic. Because when it's all said and done, when we think about high reliability organizations or hospitals, we take a stand. We take a stand for zero harm. That we want to implement policies and procedures to improve the quality of care for all of our patients. We want to take care of our staff. We want good patient satisfaction, and we want care that's equitable across the way.
Stephanie, did you want to close us off here?
There's so much going through my mind. We've covered so many exciting details. I think the combination of all the programs that American Heart Association offers, it really does help an organization to be able to improve and bring on evidence-based practice with real-time feedback right in the moment when the caregivers need it, and then be able to provide them with the results of, you practiced, here was an event, and here was the outcome of the event, and it was because of great learning took place. So it's very exciting to be a part of this and to see the next generations that American Heart Association is going in.
Absolutely. Thank you all for your summarizing thoughts there. It's been great to hear how some of these programs are working in practice and to hear some of those real world examples as well. That is all the time we have left for today's webinar. Thank you again to our three excellent speakers, Stephanie, Dr. Ash, Nancy. We really appreciate you taking the time to be here and share your insights with us today. And also thank you to our attendees for taking the time to be here as well. And we look forward to having you all at future Becker's events.